at from CLAP, PAHO, WHO, we want to welcome you to this new seminar celebrating the World Prematurity Day 2021 today. And considering the very important topics that we are going to discuss today, we are especially interested in knowing, discussing the challenges in the policies and the care of premature newborns and their families in the 2021-2030. We believe that what we're going to discuss today is very relevant, and we hope that it will be of interest to you. But we also want it to motivate you to continue to work hard for the health of premature babies and their families. So, starting this webinar, and considering that we have a very busy agenda, we'd like to give the floor to Dr. Andrés de Francisco, who's going to give you the opening words. He's the director of the Department of Family Life Promotion and Life Course of the Pan American Health Organization. Before we go any further, let me remind you that you can select the language that you want. You just have to go to the toolbar, you'll see a globe, and you can click there and choose the language you prefer. This session is going to be interpreted into Spanish, English, and Portuguese. Without further ado, then, let's listen to the words by Dr. De Francisco. Good afternoon. Welcome to this seminar where we will examine the challenges and in the pollutants and in the evidence and care centered in the premature newborns and their families in the 2021-2030 decade and the agenda. So we are about to complete this decade for the SDGs, and specifically in the plan of action for health of women, newborns, children and adolescents for 2030. We need to work especially eliminating preventable causes of death and increasing access to quality care and the quality of health care to the people, especially in vulnerability situations, reducing the inequalities and with accountability. 15 million babies are born, including 1.2 million that will be born premature. Over 30,000 of them will have from moderate to severe complications that will have an impact on their growth, their development. They will be exposed to blindness because of ROP, respiratory distress, and neurologic and digestive problems. Many of them will find it difficult to get a job, and it is estimated in the Americas that the burden of disease and handicaps because of maturity and birth-related problems expressed in QALYs and premature death reach 10 million yearly. So we need to move forward with a rights perspective, focusing especially the premature newborns and their families. The COVID-19 pandemic has had an impact that goes beyond the effects that we have observed. The plan of action for health for women, children and adolescents for 2030 emphasizes specifically the approach of the strategies that, among other expected results, are geared to reduce prematurity and adverse results at birth. That is why, from the Department of Family, Health Promotion, and Course of Life, we believe that analyzing those challenges will be essential for the next decade, with a firm proposal of attaining the goals with equality from a right-based perspective and with a commitment and involvement of all the key stakeholders. So, welcome you all to this webinar. Thank you, Dr. De Francisco. And now, going on with the welcome words, in this case, the welcome words will be by Dr. Suzanne Sarruya, who's the director and head of the unit of the Latin American Center for Perinatology, Women's Health and Reproduction. Dr. Sarruya, you have the floor. Thank you, Pablo. Thank you. Good morning, everybody. Welcome you all to this seminar. Today, we are commemorating and celebrating the World Prematurity Day. How important is this event? What is the importance of this event for what we do? We know that the first period, the perinatal period that surrounds birth, is a key period in everybody's life. We can think of many things. And we can think of the emotion and of the families and how important it is for birth and how important it is for and how quickly the children develop. So we know that living conditions, interventions, and care in these challenges at this time, from birth, during pregnancy, and perinatal, during childbirth, are absolutely critical for survival, growth, and development, not just now, but later on. And that is so important that we know that it is from there that many of the conditions will be determined for that baby to thrive and to be able to insert in a community and to have a fulfilling life, either in the community, at work, in the families, etc. So we know that the SDGs, the sustainable SDGs, demand intersectoral and sustainable actions, because we know that there's a very important set of factors that may have an impact on that development, making it sustainable, and that it is necessary to relate a number of actions so that the conditions may be there, in fact, for fulfilling development. From the Latin American Center of Perinatology in our perinatal area, led by Dr. Pablo Duran, we have 4 key axes. The first one has to do with access. We need to work to provide and to ensure universal access so that all women may recognize the right of having and receiving care during pregnancy and birth, and so that they may be integrated to what they need, and that they may receive the care and have access to care and to have access to all the professionals that take care of women from preconceptional periods until the child is born and further on. We need to ensure a quality care. We need to make women go through it with autonomy and fully aware of their conditions and their rights. And in order to do that, we need to qualify the healthcare professionals and to discuss things with them. And that is why we consider that that is such a strong access at CLAP. On the other hand, we have a special concern with the time of birth, and we know why. We know that it's the first hours and during childbirth that will determine the further development. So the perinatal time is important, and we have SDG indicators, and we especially must address the needs for quality healthcare professionals. One of the indicators is birth weight. And finally, there's a job that is essential, and that is surveillance. That is of key importance for health, public health. We need to analyze health to choose the best and the most cost-effective evidence-based interventions. That access is what enables us to move forward in the Americas. However, there are many, many challenges, and we have very high wishes. We are very ambitious. We want women to go through that period from anticonception to birth in a fulfilled manner and with full respect of their rights. We believe that there are no magic bullets. There are no special recipes. We need policies, we need programs, we need more institutional frameworks that may facilitate that care. We need qualified healthcare teams, fully committed. And may I remind you of something that is very important in the World Prematurity Day? We need to be empathic. That is, that they need to especially address the needs of the newborns, and especially the premature, as part of the entire care. That is, we need to have a broader understanding of care. In addition, we want families and society that are empowered and are capable of participating and can get engaged in their health-related decisions. It is from that perspective that we organize this meeting, and hopefully all of you may enjoy it. I hope that you can all enjoy the lectures that we are going to listen to, and we want CLAP to be a point of reference for whatever you need. We have a website that has a lot of information, and then later on we are going to have more technology available for decision makers and for mothers and the newborns, and we hope that with that we'll be able to build every day a fairer and a more fulfilling future, especially for those who come too early to this world, or earlier than expected. So thank you all for coming. May you enjoy the meeting. Thank you, Pablo. I want to thank you, Pablo, and Anna, and the entire team, including the interpreters, everybody that's behind the scenes, for your help. Thank you. Thank you, Dr. Sarruya, for your welcome words and for motivating us to continue to move forward in this same path. So, giving continuity to the words both by Dr. De Francisco and Dr. Sarruya, we'd like to briefly share with you the guidelines and the perspectives that we have at CAP on the premature newborns and their families, and what we have to consider if we wanted to reach our goals for the 2030 agenda. As was mentioned by Dr. De Francisco, in the region of the Americas, 15 million babies are born annually, and 1.2 million of those babies are born prematurely. And we know that this distribution varies, and that it varies based on the gestational age, with about 9% of the newborns that are extreme prematures under 28 weeks of gestational age, and a similar proportion, about 10%, are born from weeks 28 to 32, and a bit more than 80% are born from weeks 32 to 37. And we clearly know that these births imply that those babies will have certain conditions and needs, and they demand specific commitment and action depending on the gestational age. But in all the cases, we have to respect their fundamental rights to be protected and preserved. However, we see that even starting in the year 2000, in just a short time, there's been an increase, especially in Latin America and the Caribbean. There's been an increase of the estimated values of premature births, and you see how there's been a steady growth. So much so that these are the last global estimates in 2014, and they show that from the year 2000 to 2014, there's been a 2% increase in the frequency of premature births in Latin America and the Caribbean. At present, we are working with the World Health Organization to update these estimates, and we expect them to be published next year, and there we'll see whether this tendency continues to grow. But these figures already are an alert showing that there's a need to do something about prematurity and its consequences. And this essentially refers to what was also mentioned previously, that is the burden of disease and the burden of the disability related or associated to prematurity is absolutely significant. Each year, the prevalence of disability-adjusted years and the DALYs, these are 2019 figures, they tell us that 15 million years are lost because of congenital abnormalities or neonatal conditions, and the contribution of prematurity and its complications to that burden of disease or disability is very important, and it varies from one country to the other, and it varies a lot. So here we speak of two key aspects. One of them is conditions that will affect health, development, and they will have an impact on disability or the disability conditions, and these children, and that later on will be adolescents and adults, and they are not going to be able to enjoy their rights and are going to further increase inequalities in our populations. So premature is clearly one of the challenges today, one of the most important challenges from the public health perspective. And this is so because of what we said in terms of the burden of mortality, disease, and disability, and that is, we need to consider the implications along the life course that have increased due to the pandemic, with immediate, mid, and long-term implications. And it is a health priority because of the inequalities that favor those premature births and that are a consequence of them in time. So here we see in this chart, and this was mentioned by Dr. Sarruya, we see how the SDGs are clearly related with the premature births. And it won't be possible to achieve the goals established under this SDG framework unless we specifically address everything surrounding premature births. According to global estimates, the tendencies, the current tendencies in terms of neonatal mortality, based on the data of 81 countries globally, show that the results will be very far from what was established as the SDGs, with a 12 per thousand target. So the tendency shows that in the region of the Americas, we might be able to reach this level as a regional target. However, we've seen that the very significant inequalities in the region demand reinforcing work in this regard. In purple, you see the trend of the region of the Americas in that regard, and it's not one of the regions that show the steepest reduction. That is why we again highlight the need to approach premature births and their consequences, of course, not only to attain the Sustainable Development Goals, but also to ensure the best conditions of life and the exercise of their rights. And in the same regard, we see how without a course of life care, with considering preconception, pregnancy care, and the care of all newborns, but especially prematures and the sick neonates, it will be impossible to achieve those results. And here you see the potential effect that we would obtain if we improved this, how these interventions could help reduce the mortality among mothers, newborns, and children. Although this is very well known, both the neonatal care and the care during labor and childbirth, and in the case of the premature babies, the specific care, they all have an impact on this number of deaths that could be reduced. So here we are facing another situation of inequality. So if we have the technologies, but there is still a pending debt concerning maternal death and fetal death and the death of newborns. That is what specifically we are discussing today, the care of the premature babies and severely sick.
And as we said, we can only reach the SDGs, caring for preterm babies, without comprehensive approaches that involve having the newborn and the family in the center, the community, and universal, equitable, people-centered and integrated health services, including other players, service delivery, networks, facilities, and practitioners, the health sector in general terms with its governance, appropriate funding and resources, and of course, other sectors beyond the health sector, such as education, social security, work, and the environment. The Women's, Children's, and Adolescents Health Plan takes into account specific goals to reduce mortality and low weight at birth and prematurity, but this needs committed players and reconsideration of the challenges vis-à-vis preterm and newborn babies. In CLAP, we have considered approaching these challenges we have listed here. On the one hand, elimination of preventable deaths, and this clearly involves work regarding the reduction of deaths related to prematurity. On the other hand, improved access and quality of care where preterm, small and sick newborns are in the center of actions and concerns. Participation of families as a main axis and challenge to be approached in the coming years, and the availability of national policies and plans aimed specifically to reduce inequalities and addressing pre- and post-pandemic challenges. And last, the challenge of strengthening information systems and the evidence regarding essential interventions related to perinatal outcomes and particularly preterm newborns. To end this presentation of challenges, we wish to share with you the main lines of action at INCLAP in this decade, starting in 2021 to 2030, engage us to continue with this backward count in relation to newborns and more specifically preterm newborns. These axes for which we clearly need active participation of all players is related to the establishment of a regional framework geared to include essential components regarding neonatal health and development and implementation of national plans. In this sense, we've worked and hope that at the beginning of next year, we'll be able to introduce and discuss a policy brief and policy roadmap to approach specific health needs for newborns in the region, and more specifically, preterm newborns. And within this political framework and roadmap, include a discussion regarding the agreement regarding technologies, essential technologies and medication for preterm newborns from equality perspective to reduce mortality and pathologies in preterm newborns and make it available in all countries and populations in the region. Second, to update national plans and goals focusing on perinatal health, and this is a commitment we have been sustaining in PAHO together with the countries that will be emphasized and increased during the coming decade. Second, the elaboration of a toolkit for the elimination of preventable perinatal deaths and reduction of its impact on disease and disability. Because as we said, prematurity together with infections and sepsis and asphyxia and congenital defects are the main causes of morbidity and disability. And for this, we will start a process to create a technical regional group regarding newborn health. We will support the clinical guidelines and virtual training in relation to these four main topics, together with comprehensive newborn care. And recently there was a meeting to update the perinatal information system, agreeing together with experts in the region to create an outcome surveillance network in order to monitor during this decade all the progress made regarding outcomes in interventions. And the last component that we believe is a priority is strengthening participation and advocacy together with the family and parents networks of preterm babies. We've hosted a meeting this year and we'll have extended meetings of this sort, so countries can count with family and parent networks to contribute and actively participate in their care. In CAP, we have developed a media campaign specifically geared to babies, newborns, and preterm babies that will be launched at the beginning of 2022 in order to promote advocacy and discussions regarding newborns and preterm newborns, and announcing that at the beginning of 2022, this logo you see here, this baby, is a mobile appliance that we are launching at the beginning of 2022 so that families, health teams, in their mobile phones or tablets, be able to access information, knowledge, and materials contributing to improvements in preterm baby care and newborn baby care in general. So thank you. Be sure PAHO is working together with all the players because the care for preterm, small and sick newborns and their families is everybody's responsibility, but each of us has a role to play. Thank you for your attention. And now, after this introduction, we would like now to have this second phase of our seminar, that is specifically listening to the points of views of three key players responsible for decision-making in the ministries of health, people responsible for the teams and health teams, and the experience and standpoints of families of those born preterm, so that from each of these points of views we can analyze and take into account clearly the views from these three different places. So now we will start listening to the panelists we have invited to share their experience. First, Dr. Ronald Pérez Escobar, Director of Health Policies and Management in El Salvador, together with Juan Antonio Morales Rodriguez from the Ministry of Health of El Salvador, sharing experience in formulation of policies and planning actions at national level. Next, we will hear Dr. Shimon Belcharvis, head of the pediatrics department at the Mont St. John's Medical Center in St. John's, Antigua, sharing her experience and challenges in the care of newborns and their follow-up. And then we will have the experience of Cassiane Alves and Tiago Santos. Cassiane is the mother of Lucia and Tiago, who will share in Brazil their experience as families and with preterm newborns. After introducing the panelists, I will now hand the floor to Dr. Ronald Pérez. The floor is yours. Thank you. Thank you, Pablo. Special thanks to CLAP and PAHO for allowing us this morning to share our experiences in El Salvador when we formulate policies and actions geared to the care of preterm newborns. This week, we focused in prevention of prematurity. Please let me know if you can see the screen well and can hear me well. Perfect, yes, indeed, thank you. To start, and in the context of our country, El Salvador, you know, we are in Central America with 20,000 square kilometers and a population of 6.1 million inhabitants, and briefly share the behavior of our live borns in the integrated national health system. I will give details when I speak about the implementation of policies and tell you a bit more about our national integrated health system. We've seen a fall of live borns starting in 2015 and ending in 2020. It's quite striking. This hasn't been contemplated in the projections we had in the National Statistics Department that provides figures to estimate the different proportions and reasons and so on. Ratios, sorry. There's been this systematic fall of live newborns, and this continues in 2021. And this, at a certain point, has to be adjusted, because when providing measures at international level, we might seem to present values that are not real because the population has been estimated as larger than what we have. As to the preterm and low weight index, 7.8, passing from 8.6, sustained reduction until 2020, and in the case of low weight, similarly, the variation passing from 9.6 to 9.1. We should recall there's a direct relationship because they go hand in hand, prematurity and low weight. As for the number of preterms, if total figures, these are the total figures, 2015-2020. There is a fall, although we shouldn't be so triumphant because it's also related with the fall in live births. So although it's true, this is a saving in the case of care proper, direct care to preterms. It isn't only the outcome of actions being taken, but also related to the number of live births we've had. As for the causes of neonatal mortality in January, December 2019-2020, and compare, prematurity becomes a first cause with a slight reduction from 2019 to 2020, followed by congenital abnormalities. Indeed, we should recall that here there's a direct relationship we shouldn't forget, because although it's true there are congenital abnormalities, many of them are related to prematurity, asphyxia, third, followed by sepsis, aspiration of meconium, and pneumonia. If we analyze the behavior of preterms this year, there was something that struck us when we began to see this trend, particularly in January and February. You may observe this sustained increase from 7.98 last year to this considerable increase that has taken us to 8.73 in September. If we look 2020, it's practically 1 point up. And the explanation of all this is the impact of the pandemic, not only in problems of the mothers with COVID, because if they require hospitalization or not, we've seen this direct relationship, but also the fact that many of these mothers haven't been able to complete the prenatal controls due to the reduction of services during the pandemic. So there could be a loss of early detection of risk and infectious conditions that have this cause-effect relationship with prematurity. This led us to take actions immediately. We established a plan to approach prematurity that was comprehensive in the whole system. As for policies, we have this context, and I'll tell you how we have this policy of growing together and strategic actions sought. First, not thinking in the short term alone, as we often do at government level. The idea is to go beyond this, beyond one single administration, and plan for at least 10 years, as has occurred in the social security and health plans. The idea is to provide leadership and investment to promote appropriate care of early childhood, and more particularly children between 0 and 7 years of age, focused or centered in the family. The idea is to strengthen health system, because although somehow the state is a bit fragmented, the integrated national health system and the law supporting it allows us to better integrate all these systems, and then surveillance of the progress made. That is to have monitoring and surveillance to allow us detect the improvements, and then using these data in order to consider what is working, and this will allow us to reach decisions based on the statistics we prepare. What is important here is digital innovation, because tracing and following up the child from birth will allow us to conduct a more appropriate follow-up. In this growing together policy, the general approach is addressed to contemplate the rights and comprehensive development. It has a gender approach. It's based on the life cycle, and this approach doesn't leave inclusion aside, or the opposite. It's a fundamental pillar. This policy of care to early childhood, growing together, starts before conception. The idea is to approach situations that may impact on women. A woman who wishes to become pregnant to be in the best conditions to start her pregnancy in the right time, with the appropriate conditions both for her and her environment, to reach a good term with delivery cared in a humanized manner, providing the necessary newborn care. This policy responds to SDGs. Here we have the three most important impacts. One, the end of poverty, reducing the proportion of men, women, and children of all ages living in poverty in all the dimensions, at least half. As health, we have a role to play. If we see the whole pattern, it doesn't include that many determinants, but we can impact there. Of course, our approach requires further social and economic actions that determine good health. And the Ministry of Health plays its role, although it is intersectorial. And then the second SDG, Hunger Zero, to end all manners of malnutrition, and acting on delayed growth and emancipation in children under 5. And furthermore, this policy goes hand in hand and is closely interrelated with the social well-being and national health plans. That is, it responds to the needs posed in these plans and is in line with the indicators and goals we wish to meet in each. The idea wasn't to have you read this very busy slide, but the National Health Plan seeks to provide an institutional framework first to obtain the SDG goals, as mentioned, to be in line with the 2030 health agenda, and furthermore to be a regulatory framework to provide primary health care and comply with the universal health guidelines as dictated by PAHO and WHO. And the idea is to have a baseline, a systems diagnosis, and then start with the essential processes established in the system in order to have an appropriate system with monitoring and assessment. Briefly here, the integrated national healthcare system is governed by the Ministry of Health, and it includes social security, environmental health, and others. For example, the care of teachers and the Solidarity Health Fund in an integrated way, and governed through the Ministry of Health. And now we're going to mention how we're working in the reduction of neonatal mortality that was in the approaches, the increase of pregnant women, and the importance of breastfeeding, care with mother's milk in critical conditions. This is one of the lines to strengthen when we have strengthened the milk data and the establishment of new gathering centers or collection centers. We have begun with this year, and that's our program for the future. Increased percentage of children receiving mother's breast milk and breastfeeding. And when we see this need to establish a pattern to focus us in the care of newborns, one of the major approaches of the law isn't to approach a respectful delivery, leaving aside obstetric violence, but rather thinking in the best conditions in relation to the newborn. So we have this, and the idea is respectful and warm and sensitive care before consent.
La educación y el acompañamiento durante todo el prenatal.
So we need to be able to reach the time of birth at the time, so that we can be complying with the recommendations of WHO, and the careful care of the newborn, include the nurturing care of the newborn, including those of the most vulnerable. So let me finish just by mentioning that there's an institutional framework that makes it possible for us to approach all these issues that are being reviewed constantly, and they are adjusted to the realities as we go, and that this makes it possible for us to have a better agreement between the human capital and with the staff, both at the first level of care and at hospitals. All these guidelines should be respected. So this is a brief overview and a general overview of what we seek as an institution, as a regulatory agency, being able to establish guidelines and policies to ensure an adequate care of the newborns, and specifically the premature. So now I'm going to give the floor to Dr. Juan Morales. Excuse me, Dr. Ronald, but would it be possible to share your screen as a complete, the full page? I didn't want to interrupt you, but it would be better. Put there as view in configuration.
De acuerdo, si no...
That's all right, never mind.
Ah, sí.
¿Ahí?
Ahí, a ver.
There you are.
Ronald, disculpa, ¿me escuchás?
Ronald, my apologies, but can you hear me? Where it says configuration and visualization in the upper margin of the screen, you have to click there. So let's stop sharing so that I may see that. No, you have you can choose there. On top of the presentation, you have three options. Show toolbar, configuration of visualization. On the second one, in the second tab, you have to click there. There, good. And there, duplicate presentation. Good, wonderful. Perfect. Thank you. Go ahead.
Muy bien, tengan muy buenos días. Voy a continuar.
So, good morning. I'd like to continue with the presentation. I'm very honored to be presenting this in such an important website to show, webinar to show what our country is doing to reduce morbid mortality among newborns and what we do to ensure that the issue of this institutional agenda is really met so that we can meet our SDGs. So, from the approach of services, of course, our main work will, we are responsible for giving the information and advice and to give a continuing education. We need to transform a model that not only goes from direct care of the premature, but also start sharing and creating that direct relation with the family that will then be responsible for the care and for ensuring that that baby is monitoring. Very often we see that there are many barriers, despite the fact that we are a small country, owing to our demographic characteristics. Sometimes it's hard for parents to comply, but that's our policy as an institution. We want to promote that, and now with the law being born with love, we are working with the community to identify all those all that care, so that we can give a so that we can promote breastfeeding and and we've also seen the issue of the kangaroo strategy. We've worked at third level hospitals with that tool. And of course, we can't deny that the pandemic had an impact there, because many hospitals had to shut the doors and to have alternate plans to provide information and to be able to reach parents. And of course, we have gradually resumed each of these actions, and we also continuing with breastfeeding. Even if the baby is critically ill, the kangaroo technology helps with that strategy. And as I'm going to say later on, we are especially emphasizing feeding these babies with human milk. So, despite the problems of the pandemic in 2020, 1,388 premature babies were born, weighing less than 2,000 grams. And despite of that, we tried to keep this program operating, first of all, in the first level hospitals and then in the regional hospitals that are second response hospitals, and that implement programs as important as the kangaroo strategy. In addition, we have modified the areas to provide more comfort because of some structural issues. The spaces were reduced in such a way that the parents couldn't stay for too long. We tried to increase the feeding for the parents that implement the kangaroo technique. There are many colleagues that have used their own resources to provide training or to try to treat these babies and the families especially well. And you'll see in the next slide that we received the support of organizations such as PAHO Club to have more resources and to increase our capability of response in all the hospitals in the national network, both in the integrated healthcare system and even among the community. And we are also expanding the service for the mothers' hostels. Or we've had the support of WHO and PAHO, CLAP, of course. We have just completed the education for protocols at the hospitals of the national network to strengthen knowledge on the kangaroo strategy. Many of the colleagues are fully committed, so we have to thank them, because that has led to great expectations, and refreshing knowledge made it possible for us to change the reality so that we could see how we could approach the pandemic together with prematurity issues. We have also included screenings. There are 8 hospitals this year that are conducting screening. We are trying to make it universal. In 2020, we conducted in the hearing screening 2,098 tests. We have also organized virtual meetings to detect hearing losses and to increase the performance of a second test. And it's a problem because it's difficult for people to go from the interior of the country to San Salvador. That meant not just spending money, but also it implied a risk during the pandemic if they were to attend their appointments. Heart screening, as you saw, we also screen for an early identification of cardiovascular congenital abnormalities. And in the case of the premature, it's very important to have them well identified so as to best respond to the congenital malformations and try to solve their heart issues. And this year, in order for all the hospitals to be able to conduct that heart screening, in future months, we will increase the equipment and the qualified staff. It's not, we don't need so many technical capabilities, but it's more the capability of devoting the time and love, being directly in contact with the babies with a considerable cost-benefit ratio and a timely referral of the patients to complete their assessment. And we are about to inaugurate equipment for heart cardiac malformations, and that is going to reduce the waiting list. That's also going to reduce costs, and it's going to be instrumental for the development of our children. The metabolic screening, just a bit of history. It started in our country with hypothyroidism, but that limited us, the fact that we were constantly having problems with the capacity. We estimate that next year we will screen 80,000 newborns, and in addition for next year we were planning to increase the number of assays. The countries that want to increase their screening rates may understand that it's not just that we're trying to solve the problems with those born with metabolic problems, but we need to respond them. And we, in many cases, these are premature children that are born with metabolic issues. And in maple syrup disease is one of the diseases that has been added lately to the screening, and we're going to integrate this in a single system, information system, so that we can see all the results in the country as a whole. We are working on developing a computing system that will help us detect the cases that are positive at screening. We maintain training and continuing information, and of course the integrated health information computer. So here we have in the future, we expect to improve the centers and the banks where we collect mother's milk in different regions in the country. One in and they are spread throughout the country. We plan to inaugurate 12 collecting centers for 2024, but it's people at the territory, it's the local people that demand these centers, and we believe that we're going to succeed in inaugurating that number of centers. This year, 10 centers were certified as children's friends under UNICEF strategies, and despite the pandemic, we implemented an increase the household donations of mother's milk, and the population responded very well because they would communicate with the center. In our country is 131, and we were asked to go and pick the milk so that it would be processed. So it was very well accepted and continues to be very well accepted by the population. In addition, we are certifying the milk banks with an agreement between Brazil and El Salvador, where we work with the global network. Here you have the situation so far. We have many challenges to identify the departments that need to expand the work, the centers, but there's a lot of excitement by the teams to implement the mother's milk banks. So I think that that is here we have the team, the National Committee. I want to thank you for our program has not stopped, and this year we trained more than 100 trainers at and obviously we have the certification by the American Society of Pediatrics, and this committee surveys this to achieve the certification. So we want to thank you because it's a joint work with the American Academy of Pediatrics as we try to improve the quality of our newborns care. Transfontanellar ultrasound. We are trying to decentralize this ultrasound. Sometimes it's an expenditure. It's not affordable in some areas, and it's especially difficult to have trained staff. And for 2022, we are going to increase the training of the resources that are absolutely ready to do it, and people are ready to come to El Salvador to train the people at the women's hospital. And I wanted to thank the colleagues that are working to decentralize that service and to increase the services to the most vulnerable population. Obviously, we had the administration of human milk at the neonatal intensive care unit. 1,400 newborns have benefited, and the mothers that donate the milk are 4,200. And with promotion, we have tried to promote an early bonding and the late clamping of the umbilical cord and breastfeeding in the first half hour of life. We wanted to ensure that through the single birth code, and we are working with PAHO to achieve traceability of the countries. And we are also working at an early and timely identification of infectious diseases. We are working that with to reduce the cases, and today more than ever with the pandemic, we are monitoring and referring babies with congenital abnormalities. And we want to again thank PAHO because we are completing in these recently a course with updating on surveillance systems and an adequate identification and classification of congenital malformations. We're also working to monitor the prematures in the community. We organized a course for the comprehensive attention of the premature with 40 hours, and we had a good attendance despite the pandemic. We have trained more than 100 people on the information system that was completed in September, and we're also working, as Rana said, to update the neonatal guidelines. And obviously, that includes monitoring the premature. So here, I'm showing you how from the First Lady has played a key role in the implementation of the policies. She increases the visibility of prematurity as a problem. So we created this this week, and we are not just going to limit it to a week, but we're going to work all year long to obtain excellent results in the 2030 agenda. Thank you. Thank you. Thank you, Drs. Ronald Perez and Juan Morales. That was a very enriching and a very comprehensive presentation, and we have a clear idea of how El Salvador is working in improving the quality of care of newborns. Now, going on with the agenda, we'll give the floor to Dr. Charis from Antigua, who will present her experience.
Greetings, everyone. Thank you, Dr. Duran, and I'd like to thank PAHO and CLAP for the opportunity to present this morning. I want to say happy belated World Prematurity Awareness Day to everyone, and I'm hoping that we all enjoyed it. Now, I have dubbed the presentation this morning as Quality Gaps in Neonatal Care, the Tale of a Twin Island State, and I have nothing to disclose. So, we recognize that poor perinatal outcomes continue to be a significant global health burden, and many neonatal deaths in developing countries can be avoided by simple, low-cost intervention. High neonatal mortality rates continue simply because there are gaps. Coverage gaps, which are defined as unavailability of services, and quality gaps, where the service is available, but is either inadequate or ineffective. And so here in Antigua and Barbuda, in the Caribbean, we are a population of about 97,928 based on 2020 data, and we have just over 1,000 live births per year. So before we can understand the challenges that are faced by us here in Antigua and by extension likely the Eastern Caribbean, we have to understand the context in which we practice. And so in our neonatal intensive care unit, we have 15 beds. We're staffed by 2 consultant pediatricians, a senior registrar, and junior physicians. We have neonatal trained nurses, registered nurses, and nursing assistants, as well as a visiting pediatric surgeon. Currently, our viability has been adjusted to 24 to 26 weeks and 680 grams, or 26 weeks and beyond. But I must say legally that our age of viability is actually 28 weeks, and we're working on adjusting the legislation. In terms of support that we're able to give, respiratory-wise, we can offer mechanical ventilation, nasal CPAP, and surfactant is available free of cost to our families. And we have recently embarked on a project of starting TPN, and we're hoping that this will be consistent amongst all those who are at risk. In terms of our first-line antibiotics, we utilize ampicillin and gentamicin, and we actually serve as a referral center for Anguilla and Montserrat, and we also offer newborn screening for sickle cell disease as of last year, and we've screened over 1,000 newborns, and here now I'm going to basically take you through very quickly some of our statistics. Let me just move this quickly. There we go. Okay, it might be better up here. Okay, so in terms of total number of admissions, you see that we admit anywhere from just over 300 to 425 newborns. Well, of the newborns, 425 admitted to the NICU, sorry about that. And in terms of the total live births, you can see that we range anywhere from 1,058 to just about 1,159. And we admit anywhere from 31 to 38% of the live births. Now, when we look at the male to female distribution, We recognize that over the years, from 2015 to 2020, our males have predominated, where we have anywhere from 171 to 237, and the females have followed a similar trend. Now let's look at the distribution based on gestational age. As is expected, most of our babies who are admitted are greater than or equal to 37 weeks, followed by those who are late term and very to moderate preterm, and then extremely preterm. And this is expected. We are happy that we don't have much in terms of unknown data, and this is due to the hard work of our staff, to include Dr. Richardson, as they work hard on the SIPs. Right now, SIPs is paper-based, but we're hoping to become electronic soon. Now let's look at the breakdown in terms of the admissions based on whether you're term or preterm. So as said before, up to 75 to 85% of our admissions to the NICU are term, and the rest will be preterm. But let's look at the breakdown. As expected, anywhere from 10 to 16% would be our late preterms. Very to moderate preterms range anywhere from 7.2 to 11%. We had a low of 4.2% in 2020, and the less than 28 weekers we have ranging from 0.6% to 3.5%. Last year, we had 1.5% of our admissions being represented by the extremely preterm infant. Now, distribution by weight, as expected, we have a nice bell-shaped distribution curve where most of our babies will be of normal birth weight, and then we have our outliers who would be of extremely low birth weight and who would basically be greater than the 4 kilos or macrosomic. Now, let's see. Those who are of extremely low birth weight would range anywhere from 1 to 3.8%. Those who are very low birth rates would range anywhere from 3.4 to 4.2%. And then we would have our 1,500 to 2,400 grammars being 16.7 to 18%. Our greater than 4 kilos, we would range anywhere from 12 to 14%. But as we focus on those who are premature, we have to monitor them in terms of complications. Respiratory-wise, we can see that in terms of our bronchopulmonary dysplasia or chronic lung disease, we range anywhere from 4 to 10 babies per year. And in terms of our respiratory distress syndrome, we can see consistently that we have anywhere from 20 to 40 babies per year with RDS. We're happy that the numbers who are receiving non-invasive support have been increasing over the years, and we're also thankful for the free availability of surfactant, which has made this even more possible. Now, in terms of our neonatal deaths, we can see that our early neonatal deaths were on a high of 12 to 16 within the years, but we're happy to report that in 2020, our early neonatal deaths came down to 5. Our late neonatal deaths were basically consistent over the past 5 to 6 years. Now let us look at the outcomes of those who are between 500 to 1,000 grams. We're happy that we've been doing better. As you can see, in terms of survival in 2015, of basically the 5 babies that we would have had, 3 would have survived and 2 would have died. But as we would have progressed in years and as our quality of care would have improved, we've now moved to the point where we have, of the 16 babies being born, less than 1,000 grams, 11 surviving, and 5 would have unfortunately demised. As we look at the babies who are of greater than 1,000 grams, we see that we are also doing a bit better with them. 2019 was a difficult year, but outside of that, basically we're having few of those babies who are demising. Now, what are the causes of death, you may ask? And as you look on this table, it becomes quite clear that we are following what is established internationally. Complications of prematurity are leading the pack, followed by asphyxia, congenital disorders, cyanotic congenital heart disease, and sepsis. So we recognize that this is definitely an area that needs to be improved, and therefore we need to identify the gaps in quality of care that is being offered. So again, emphasizing complications of prematurity, followed by asphyxia. Let's look at our congenital disorders, which you can actually combine congenital disorders with cyanotic congenital heart disease in terms of defects, and then sepsis. Now, what has been our neonatal mortality rate? From 2015 to 2020, 11.6 per thousand, our stillbirth rate 11 per thousand, and our perinatal mortality rate 21 per thousand. It's important to note that in 2020, our neonatal mortality rate actually went down to 6 per thousand, for which we're very happy. But it's not just about one figure. We really have to look at the trend to see how we can improve overall. In terms of our sustainable developmental goals, we recognize that we must decrease the mortality amongst those who are under 5, and we must strive to maintain our neonatal mortality rates to less than 12, and in terms of the Ministry of Health standard, to less than 10 per thousand. And so what are the gaps in neonatal care? Well, for us, unfortunately, coverage gaps where the service is not available. Cardiology services are not available in hospital, and therefore many of our diagnoses are made on a clinical basis. If we have a patient who has patent ductus arteriosus, then basically it is a clinical diagnosis and it is presumptively managed. Unfortunately, we do not have prostaglandins available to us, and so we recognize that we have a significant challenge here. We do not have a birth defect registry, and that needs to change in the very near future. In terms of quality gaps, so remember we said that quality gaps are basically where the service is available, but it may be either ineffective or inadequate in terms of the quality of service delivered. Human resources, that's a significant challenge. We basically have 2 pediatric consultants at the hospital, and we're basically managing the neonates to include our premature infants, older children up to the age of 16, as well as managing data. So you can imagine how challenging it can be, especially as it relates to data where we're paper-based, so everything has to be calculated physically. It can be enormous, especially with COVID. It has even put a greater burden on us. Data gaps. We find here in Antigua and Barbuda and even across the region that we have a lot of data, but unfortunately our data is not being analyzed as it should be or in a timely manner, and it is not being utilized for change in policy, but that has been changing over the years, and we're thankful for that. So data does exist, but we need to more efficiently analyze and also disseminate in order to activate change. Remember that data that is collected but is not analyzed is basically useless data. Nutritional support. So we are striving to become a breastfeeding friendly hospital. Unfortunately, we do not have breast milk banks. Many of our babies do receive breast milk exclusively post-delivery and definitely before discharge. But unfortunately, many are also mixed fed, and I'll show you some graphics later on. So we need to work on breastfeeding. We need to work on public education so that this can improve. And for those who have challenges with starting enteral feeds, we are striving to start our TPN program, formulating a policy that will guide this. In terms of respiratory support, we're happy that we can offer mechanical ventilation, but we definitely need to improve our non-invasive support so that we can continue to have improvement as it relates to chronic lung disease or bronchopulmonary dysplasia. Pediatric surgery services. We have a visiting pediatric surgeon, but many a times if we do have an emergency that requires immediate intervention, it is either a general surgeon who would intervene, or we'd have to sustain the neonate until the surgeon is able to come. And so this is definitely something that needs to be improved. Policies. We're currently working on a neonatal policy manual so that standard of care can be the same across the board. Remember that we also have many persons who are junior, and so we definitely need to have policies that can guide practice. Infection control, neonatal imaging, newborn screening, training, and advocacy are also areas that we need to improve. We're happy that we've started newborn screening for sickle cell disease, but we need to screen for other diseases that are common in our diaspora. Neonatal imaging, unfortunately, we cannot do imaging on the floor except for x-rays. So our neonatal echocardiography, as well as our cranial ultrasounds, unfortunately cannot be done until the baby is more stable. As we said, in terms of echocardiography, we do not have in-hospital services at this time. We recently had an adult cardiologist who is willing to assist, but again, the baby has to be stable and it's preferred to be over a month of age before that scan can be done. And we have to advocate for our parents. So what have we done so so far in quality improvement as I seek to wrap up. You would notice that we have basically been looking at skin to skin, so I will guide you given the disturbance here. So this was a quality improvement program that was undertaken in conjunction with USAID Assist, and it was basically an 18-month program which was successful. So initially, we were not actively practicing skin to skin, and we had significant rates of hypothermia. And so if you follow the graphic here, what we would have done is that we would have done a baseline rate of skin to skin prior to education and prior to collecting data. And then, so we would have gone back in time prior to the onset of the project, and then we would have started collecting data subsequent to training. And you would recognize that we started off with rates of skin to skin at about 32%. Thereabout in August, September of 2018. And you'd recognize that post-training, that we would have had a consistent increase to almost 100%. And of course, we'd be doing our plan, do study act cycles, and continually reviewing the data to ensure consistency. This reflects basically the rates of hypothermia, and you'd recognize that initially we would have had a nice trend downwards as expected. So as the rates of skin to skin would increase, then you'd expect that the rates of hypothermia would decrease. We recognize a slight trend upwards here. And so again, you need to review what is happening in your unit. Is there a change in terms of the ambient temperature? Is it that we're not doing skin to skin for a long enough time period? So again, it requires us to do our fishbone analyses, asking the 5 whys so that we can continue to have improvement. Now, the percentage of babies born who were breastfed within the first hour of life. Again, similar thing where we analyze the data before education, and then we would have started collecting our data, and then you'd see we would have had a consistent increase to almost 100%. But look at the contrary, where we're looking at the number of babies who continue to be exclusively breastfed at discharge. We are not at 100% at all. We're actually spanning roughly 80%, and so there's room for improvement. This can also be explained by the fact that for those babies who are admitted to the neonatal intensive care unit, we do not have an overlay room. We also do not have a rooming in policy as it relates to the NICU. For the postnatal ward, it's different. And so once the mothers are unavailable and they do not have expressed breast milk, then formula is utilized for these babies. So these are some of the reasons that our rates would not be at 100%, and we definitely would have to improve. And I take you now to Zika. We, in conjunction with USAID Assist, were also able to monitor our babies and families who are potentially affected by the Zika virus. And so Zika Mass is actually a Zika case management software where we're able to assess the quality of care provided to mothers and children with symptoms suggestive of Zika. It definitely was able to produce surveillance reports, and it was able to improve the quality of care based on the fact that we're able to coordinate care and facilitate input from all actors. So when persons would have seen babies who would have had developmental delays or who had concerning head circumferences, once they filled out their forms, then they would be sent in and the data would be entered into this database. We were also able to gather critical information to provide timely follow-up and address all the needs of affected children and families. So the Zika Mass tool actually has the ability to flag when a patient is late for a follow-up appointment, to flag when a patient has had a late intervention or investigation done. So if a patient was supposed to have their repeat thyroid function test at 1 year, then the system is going to flag it if a result has not been entered. And so this helps to improve the quality of care and also helps us to coordinate care as we can then reach out to other stakeholders. So again, we were able to adjust and even set care standards, and it was able to monitor compliance. So again, if you look very vaguely here, you can look at things like, was the repeat head circumference done, and it gives you the rates. And of course, it flags if something was not appropriately done. So as I close, sustainability. In lower and middle income countries, sustainability is a significant challenge. Why? We have the impact of culture. Sometimes we see it as, I've always done it this way, and this is how I'm going to continue to do it. And so evidence-based practices are sometimes not embraced by all persons. Leadership. The leadership definitely has to be interested in change and quality improvement, and also has to be interested in motivating their staff, moving along with their staff to ensure that quality improvement takes place. We have to be innovative, especially in times of COVID. We recognize that as a community, we're not restricted to challenges here in Antigua and Barbuda, but the challenges are similar across the Eastern Caribbean. And we may have different skill sets across the Caribbean, and therefore, if I don't have somebody to assist with screening here, then someone else can potentially assist me with screening. And so World Pediatric Project has been very helpful in assisting us with echocardiography, and they actually do cardiology clinics at least once per year. And so that is a way in which we can share skills amongst each other. Human factors, we spoke to the fact that sometimes we are short-staffed, the staff is fatigued, you have competing priorities because you're trying to do essential newborn care, you're trying to also improve in terms of neonatal resuscitation, and many things are happening at the same time. We have to engage. There must be public-private partnership. No one can fight the battle of prematurity alone, and it often takes significant funding, need of equipment, and so definitely that's something that we need assistance with. Empowerment, you have to empower every member of your team. You have to go from the top down and the bottom up if you're going to have improvements in our prematurity care, the quality of care. Measurement, our previous presenter spoke about monitoring and evaluation. We have to look at indicators. If we're not looking at what we're doing, we will never change our practice. We have to look at the knowledge into action. So training is key. Neonatal resuscitation, parenteral nutrition, respiratory support. How do I do a quality improvement project? All these things have to be taken into account if we're going to sustain changes here in Antigua and Barbuda and across the Caribbean. So with that, I thank you. I must continue to thank the members of staff here in Antigua and Barbuda, the nurses, physicians, technical staff, housekeeping, administrative staff, as we have definitely seen improvement in our neonatal care. I must thank our partners, PAHO, CLAP, WHO, as well as WPP, as we strive to continue to keep our neonatal mortality rate less than 10 per thousand, and as we strive to definitely decrease our rates of mortality in the under 5. Thank you very much.
Muchas gracias, Dr. Chapman Jarvis. Excelente presentación.
Thank you, Dr. Jarvis. Quality improvements and gaps have been well indicated. She's a champion also at perinatal level, and unfortunately, we haven't been able to visit the country and work in the perinatal analysis promoted by the country. And we're sure that in a short time, we'll be able to participate in this activity. And now, as stated, we pass on to the third group of presentations, in this case, from the standpoint of Cassiane Alves, the mother of Luisa and then Pio Santos, who will share with us their experience as families and early preterm babies. So now I hand the floor to Cassiane Alves.
Bom dia.
Bom dia, Cassiane.
Tudo bem. Eu sou a Cassiane Fernanda de Oliveira Alves. Tive prematuras extremas de 23 semanas aqui em Porto Alegre, Rio Grande do Sul, no Brasil.
In Porto Alegre, Rio Grande do Sul, the baby was born with 600 grams and Livia 570. Olivia died 3 days later, and Luisa continued struggling for life. Luisa passed through many intercurrences, and there was a certain expectation because physicians couldn't think she would live, and it was a twin pregnancy, so survival was a bit more difficult. There were infections, well, everything that preterm babies have occurred to Luisa. Some days later, she left hospital, and now she's going to be Annie is an expert, and please, and people embrace the case of preterm transcendence.
Luísa, essa aqui, quando ela tinha...
And this is when she was 18 days old. Today, she's a beautiful girl, and every day, well, she has some sequela because of prematurity, but she's getting better and better.
Vocês podem estar ouvindo choro daí.
Well, maybe you can hear her crying because she knows that I'm telling her story, and she cries when she hears her own story.
Quer aparecer aqui, criança? Vocês têm alguma pergunta, alguma coisa?
Do you have any questions? You may ask me.
Muchas gracias, Casiana. Realmente, como mencionaba,
Thank you. Really, as we said initially, it's our interest.
perdón, es nuestro interés.
We are interested in having the families too, and having their voices heard, and we want them to get actively involved in care. So the question is, out from your experience, has been the challenge in terms of participating in the care of Luisa? And what would be the suggestions so that you can all be actors? Well, the experience really, it's in my case, I had a twin pregnancy, so we don't expect anything bad to happen during pregnancy. So I got to the hospital, and at the time that I was already with a dilation, but 23 weeks of pregnancy, it's very difficult for babies to survive. So you have to prepare yourself for the worst. I was not prepared. But when they were born, Luisa had to be in the incubator, and I never left. I got to the hospital at 7 a.m. and I spent there the entire day, and until 1 a.m. to be able to be with her, to know what was happening, and so that we could participate of her evaluation, because the doctors, the nurses, everybody was so supportive, and it helped me, and they gave me the comfort, saying that she would overcome all that situation, and I felt very supported, and I felt their hugs, I felt their warmth, and they were always convincing me that the baby was going well, and she started taking 1 milliliter of milk, just 1 milliliter. That's what she started with. But I still remember how moving it was. And it was essential to. And every November 17th, we get together to show how our babies are doing. And the neonatal period is, the newborns place, it's a place that, well, when these things happen, you never know where you are getting your energies from, and it's incredible to see what those babies are going through and how strong they are despite the frailness. And so I learned that my girls are the only thing that I care about in life, And I also believe that if you have faith, things will happen. And Luisa shows me every day when she learns something different. She is an evidence that despite the very difficult times, sometimes they call me, and when somebody is born, they call me, and they sometimes ask Luisa's mother to come and to encourage the mothers that are going through the same, to show them that things can be done and that you can get good results. So until you go through that, you cannot tell. After the fright, you can breathe, you can think, but everything happens when it has to. I experienced that positively because I was supported by the neonatal unit, and they gave me the strength that I needed to take care of the preterm babies. So I encourage all the staff to continue working like that, and those mothers that are going through problems to trust the staff and to open and I am very happy to share my life experience. Now it's 4.5 months, but I would go through the same. It was such a positive thing in spite of all.
Pablo, no se te escucha ahora.
Es impactante, Cassiane.
Yes, it's so impressive. Thank you for your commitment, and also for motivating the changes in the comments in the chat, for congratulating, but also for perceiving that strength that is so contagious. And what you mentioned is very important, both in the 4 months that you went with Luisa at the ICU, but also what comes after that, because not everything is over when a baby is born premature. Of course, they can come back, but there's also a path from that day on, and sometimes you're not so accompanied by the healthcare team because you have the fears. Briefly, could you tell us the experience? Did you have the knowledge? Or is it something that we need to promote in the country so that the accompanying goes beyond the fact after the hospital?
Yes, after discharge, Luisa continued with multidisciplinary treatment with the physicians in hospital, and when I got there, people helped me, and at home I felt a bit alone, and I even waked up in the night to see if she was breathing. I was a bit afraid. I didn't have the same support as in hospital. And at the beginning, I also had difficulties for breastfeeding. She had to adapt to a different bottle and mother sitting and things of this sort. I was a bit afraid, but I'm very grateful for the support network. It was wonderful. Well, not everybody has a support network. In hospital, my parents, my father-in-law could be there 30 minutes per day, and my parents went every day, 34 days, every day. And I did need them at that time, and they also needed that warmth. And the support network continued at home. Luisa growed, and I discovered that she had a palsy, a sequela of prematurity. So I began to treat her with orthopedic surgeon, ophthalmologist, with this very nice multidisciplinary team. It isn't easy because the treatment continues. It's a girl that is healthy. She is low weight for her age, but she never went back. She's always improved. But we always have this support network. I don't always have the necessary medicine. At the beginning, it was a bit more difficult, but we must continue struggling. I always say this. If Luisa continued to improve, to learn to breathe, and so on, so will I. I will do my bit. Even if it's hard, because Luisa only began to walk at 4 years of age. So, since her birth, there wasn't a day where she wasn't in physical therapy. Well, in the routine of a mother of a normal baby is not the case. Luisa always had a physical therapist, a speech therapist, and it isn't easy, but you can do it. For many families, this is extremely difficult and hard, according to the care provided and the place where they live, because this is something we really have to struggle. We know many stories of this sort, of parents who don't always manage to do what I managed, because I had this very, very important support network. So things were a bit difficult, but we managed.
Y realmente, bueno, seguimos viendo los
we're reading the comments made in the chat. They're always very complimentary, and what you say in this regard, well, I'll highlight a couple of things. One, the grandparents and parents visiting. This is something we're trying to encourage, of course. They shouldn't be considered as short-time visitors, but rather as active participants in this care. Apart from the mother and the close caregivers, the rest of the family is a contribution always. And the other comment regarding the support networks you mentioned that accompany in this very difficult process. Physical therapy every day is really a hard job and is a great demand. And if you don't have these networks, we imagine it would be much more difficult. That's why it's so important to hear your comments so that in the different countries and health services, mothers and fathers and grandparents be heard so we can learn from their needs and experiences to accompany them and promote the necessary care. So what we've heard has been extremely important to us, and we trust that in the countries in the region, the networks grow. So we are committed to contact you and the different networks so that increasingly the voices of families be included in the formulation of policies and providing care, so that they are present, so we can all do our bit. Thank you so much, Cristiane. Thank you. All the best for Luisa. And as we said at the beginning of the seminar, giving a voice or listening to you is extremely important, and also those who were born in preterm. That's why we wanted to have the testimony of Tiago, who was born preterm. Unfortunately, he's in his work hours, but he's shared his testimony and will now listen to the recorded version. Thank you. I'm Tiago. I'm 23. I am from Porto Alegre in the south of Brazil. I'm a volunteer in volunteers.com, Brazil, and we're very pleased today to participate in this event to tell you briefly about my birth. I was born at 34 weeks, and according to my mother, in the last gestational age, she had an important headache and in her tummy, and due to this, she was carried to hospital for a preterm delivery. There were many complications, however, with all the support of the family and mainly of the health team, physicians, nurses, and nursing staff in general, everybody made things work well. After delivery, I had a blood infection that caused me staying in the ICU a couple of weeks, receiving antibiotics and all the treatment planned. That was useful, but it wasn't so easy. These weeks were very difficult for my parents. My father worked the whole day long. My mother depended of my grandfather to carry me to hospital, and he carried her to hospital every day, rain and sunshine, and always back home with great anxiety. Of course, she wanted to take me home. There were very many consultations, but the news was that my stay would be longer in hospital until one day I improved and could go home. Care continued there. I had reflux until my 12th month of life, but throughout, until 5 years, I received special medical care to reach today, and I live very well, as if I had been born at term. I go to university. I lead a totally normal life. I read, I study a lot. That's it, basically. I would like to highlight that my family really provided support always, and I'm very grateful for all their care. So everything ended well. Without them, nothing would have been possible. And of course, I shouldn't leave aside and thank the physicians and the whole health team that worked with me those first years, where they provided the necessary care. And I also wish to highlight that I'm very happy to participate in this sort of event. I have participated in other events of preterm babies in Brazil. It's something that we don't discuss a lot, and I think it's very important. More people should be aware of all this. It's not the same if you're born preterm. So this is something we must work on with the health staff and the family. It's very important. After I started university, I studied a bit more this topic and asked the people who were close to me about this, but they knew very little about the importance and severity of prematurity. So I'm very grateful about this and compliment you for this wonderful work, allowing people to live longer in a better way. I have a t-shirt, a red t-shirt, And I'm very grateful.
Muchas gracias, Tiago,
Thank you, Tiago, for your testimony.
Muchas gracias
And thank you
a los panelistas y a las panelistas
to
por
all panelists
ricas
for this
presentaciones,
wealth of presentations,
testimonios y experiencias.
experiences highlighting
Principales que surgieron
the
en
main
cada
aspects that came up
presentación,
in the different presentations.
claramente como la
We
experiencia
clearly
de El
observe
Salvador, con el
that the
compromiso
experience in
de los
El Salvador and the commitment of the people responsible at the different levels, because people mentioned actions arising from the First Lady's office and others from the Health Ministry, that clearly show that vis-a-vis political decision-making and implementation of actions at all levels, we can reach the expected outcomes. And clearly the experience in El Salvador leaves us with that view of their commitment that motivates other people according to their characteristics, responding to with policies and implementing training strategies and policies to achieve the expected outcomes. And the presentation from Antigua and Barbuda were clear now that the gaps that must be worked on are very important. The reality, as presented by Dr. Bell, is in line with what we saw in El Salvador and is registered at international and regional level as for the importance of the figures of preterm babies and the corresponding challenges. But these gaps are similar, although with differences as occurs in other countries and populations. But clearly, the experience of improvements in quality and surveillance regarding essential practices as breastfeeding early on or the approach of sepsis are lines to be developed in the countries. And last, the voice of Cassiane and Tiago that bring closer and move us, because it isn't just a visit or to the health centers or statistics that should drive us to intervene and extend the framework of rights, but the personal histories behind each of these 1.2 million preterm births that occur every year in our region. So from PAHO and CLAP, we're quite convinced that indeed, apart from appreciating the statistics and figures behind and before, we have individuals, mothers, families, grandparents, children, and fathers that grow and develop and require this whole framework, be it policies, care in the health services, and society as a whole, to respond to these needs and thus promote quality care in the framework of rights. From my standpoint, I want to thank each and every one of the panelists and the whole CLAP team that contributed to this seminar, and indeed each of the participants, because this will motivate actions. So thank you. And now we hand the floor Dr. Cerruja.
Muchas gracias, Pablo.
Thank you, Pablo. Session is a bit different from what we're used to, but ends with this emotion of listening to Tiago, Cassiane, and Luisa, of course, and show what we're working for. I think this is what it's all about. Since yesterday, I am carrying something this color because it's a color of prematurity. It's something I learned. And as I said at first, we work to have decision makers as we have in El Salvador and in Antigua and Barbuda and in many of the countries working with us, and people like you. We are over 200 listening 2 hours to all the presentations, open to think about the role of each of us in this moment where it's more than ever necessary. I think we're going to be 2 years of pandemic where there were many restrictions and challenges, and we need to overcome this and do so with empathy, solidarity, acknowledging the value of the work of each as parents, grandparents, family. And this is what we heard today, I think. Different views that add on, because that is what it's all about. We all need to work together. So thank you, Pablo, for this very beautiful celebration of this day of preterm babies, the whole team, Anna, the interpreters, our lecturers. Thank you for the time to be here and be available. Cassiane and Tiago about their personal experiences, all the people, speakers who spoke about the experiences in the countries, and you who were listening. Please share this video, speak about this. More than ever, it's the right time to make progress in this area. Many babies who will thank us. Thank you.
Muchas gracias, Susana. Y entonces,
thank you, Suzanne. In this way, then, we close our seminar. And as Dr. Saruja said, the seminar will be available in the YouTube channel of Tahoe, so you can share it with all those interested. Let's ask people to open the cameras so that we can make a picture. Cassiane, Tiago, if they're still there, please, so we can take a picture of all the participants. She's thanking the different colleagues. Tiago, Cassiane, people from El Salvador, from Antigua and Barbuda. Have a nice day.
Muchas gracias. Igual.
Thank you. Greetings to all.
Bye, un saludo, gracias.